Welcome to Next Fellow. I'm Dr. Narendra Allav. Today we are going to discuss topic burns. So burns we are dividing into two videos. In the first part, we'll discuss the pathophysiology of burns and the care of the burns patient and criteria for admission into the burns ward. And management of burns, we'll see the assessment of burn surface area and assessment of depth. In the second part of the video, you will be we will be dealing with uh, fluid resuscitation, care of wound care, and also the non-thermal burn injuries. So let's get into the topic. Burns can affect various organ systems. The most common organ affected is skin. Uh, so respiratory system can be affected, especially when the patient is trapped in a closed space, like in a burning vehicle or a burning building. So when the victim is in the closed space, the hot gases they inhale can burn the nose, oral cavity, and larynx. If there is steam has high latent heat, so it can cause damage even the subglottic area, in the lower airways also it can damage. And there is also a chance of inhaling poisonous gases like carbon monoxide and hydrogen cyanide. So carbon monoxide is a product of incomplete combustion, so mostly seen in the fires in enclosed spaces. So if you identify victims unconscious or with altered consciousness in the fire area, probably it could be because of carbon monoxide. This carbon monoxide has high affinity for hemoglobin. It has 240 times more affinity than oxygen. So it blocks the transport of oxygen. Once carboxyhemoglobin is formed, it's more than 10%. It's dangerous to the person. So they'll require a therapy of pure oxygen for at least 24 hours. Other poisonous gas is hydrogen cyanide. Hydrogen cyanide, we know, interferes with metabolic respiration, so it can cause metabolic acidosis. Other risk factor is there is chance of inhalational injuries. Uh, uh, when the flames go up, small particles fly along with the flame, and so these can be inhaled and they can deposit in the alveoli. This can cause chemical pneumonitis. So this will cause decreased gaseous exchange. And later, after 24 to 48 hours, patient might develop bacterial pneumonia. These patients can have poor prognosis. Other type of injuries that can decrease ventilation is mechanical block. That is when there is full thickness chest burns, the rib movements might be hampered, and then the patient might not be able to ventilate. That's another reason for respiratory or decreased ventilation. Circulatory system is the other system that can be affected. So this directly happens because of the burn of the skin. So whenever there is burn injury on the skin, it activates web of inflammatory cascades. These inflammatory cascades will alter the permeability of the blood vessels. So there is increased permeability, and then this intravascular fluid escapes into the extravascular space. And as the burn injury increases, the permeability also increases to such an extent that even the large protein molecules will start going into the extravascular space. So the burnt collagen, the burnt tissue, this extravasated protein, all these increase oncotic pressure outside the vessels. And so more fluid will travel from intravascular space to extravascular space. So because of this movement of the intravascular space to extravascular space, there is decreased intravascular volume. This happens in the first 36 hours of the burn injury, and maximum happens in the first 8 hours. So small burns, this phenomenon is localized to that small wound. But if the burn is more than 10% in children or more than 15% in adults, so if burn injury is more than 10 to 15%, the amount of fluid transfer from intravascular space to extravascular space can be so great that it can cause circulatory shock. And if it is about 25%, if burn injury is about 25% of the body surface, there will be fluid loss from the vessels even remote to the burn injury. That means the vessels that are remote to the burn injury also start losing fluid because of the inflammatory effect on these vessels. So burn surface area is very important in resuscitating the patient. Other effects or sometimes peripheral circulation might be hampered because of the circumferential thickness burns, full thickness burns. If these sort of burns are identified, we have to do immediate eschorotomy and decrease the pressure so that the circulation is re-established. And similarly, immune system also is affected in burns. There is a decreased cell mediated immunity in burns, and also there are a lot of potential sources of infections in a burns patient. The wounds itself and the central lines, tracheostomies, catheter sweepless, all these can be a potential source of infections. GIT is the other system that is affected. The inflammatory cascades and shock can lead to microvascular damage and ischemia of the gut mucosa. And then there is also decreased gut motility. All these phenomena will also lead to translocation of gut bacteria. This translocation of gut bacteria can also act as an important source of infection. The gut mucosal swelling, gastric stasis and peritoneal edema will also lead to abdominal compartment syndrome. That is, there is increased pressure in the abdominal compartment. This also can put pressure on the diaphragm, further decreasing the efficiency of the respiratory system. So these are some of the important organ systems that are affected and that we have to keep in mind when we treat the burns patient. So care of the burns patient starts at the pre-hospital, at the burn site itself. The first and most important thing is ensuring the rescuer safety. The rescuer himself should not become a victim. He should wear all the safety gear and he should know what type of fire it is and how to put it off and how to safely rescue the victims. And then the burning process has to be stopped. You can stop it and then roll the patient to stop all the burning process. And then you have to check for other injuries also, non-burn injuries also. The furniture might fall down or the patient might or the victim might jump out of the burned buildings, and there could be other potential injuries happening. So we have to look for other injuries also. And then once the burn is stopped, we have to cool the burn wound. Cooling of the burn wound with normal water. So this has some potential advantages. The first and foremost, it itself acts as a analgesia. Some amount of pain relief will be there, and it also slows the microvascular damage that happens the post burn. At least we have to do this process for at least 10 minutes. So if you are in a cold climate, in temperate climates, you have to be sure that if you are using the water, you should be sure that you should not let the patient go into hypothermia. That is the only thing we have to keep in mind. And then the patient should be given the support of oxygen, especially if the victim is in the closed space. Make the patient sit, and then if there are any burned limbs, elevate them to decrease the edema and save the peripheral circulation. So some patients will require a special care in the burns ward. So a patient with inhalational injuries or the airway injuries or those who require fluid resuscitation, that is burns greater than 10 to 15%, or those who might require surgery like eschorotomy or full thickness burn excisions, or any wounds on important surfaces like the hands, feet, perineum, face, or patients with psychiatric or social background who are not advisable to be sent back home, or if you are suspecting any non-accidental burn cause for the burns, and then extremes of age, and then the burns which are associated with some serious sequelae like high tension electric injuries or concentrated acid burns. All these cases we have to admit them in the burns ward. So managing of burns patient, like in any other trauma, it's ABC, airway, breathing and circulation. Airway. So what happens particularly if the patient is in a closed space and he has inhalational or airway tract injuries, we should intubate the patient electively. So there is a high chance of patient developing laryngeal edema, and then the intubation might become difficult. So this laryngeal edema can set in anywhere between 4 hours to 24 hours, and then the swelling could persist for 48 hours. So until then, it's better to intubate the patient electively and keep the intubation. So whenever you are intubating the patient, always keep the uh, tracheostomy set beside you, so that if intubation fails, you can immediately go for tracheostomy. So don't wait for the symptoms to develop to intubate the burns patient when you're suspecting airway injuries. So the symptoms come only when there is laryngeal edema. At that time, it's very difficult to intubate the patient. So those symptoms are change in voice, stridor, anxiety, and respiratory difficulty. All these features of laryngeal edema come late. They come only after laryngeal edema sets in. So more than that, it's better to rely on the history. History of the patient is in the closed or in the trapped in the closed spaces. So that is your red flag. That's where you have to think of elective intubation. And some signs like blisters on the hard palate, the burned nasal mucosa, the hair in the nose is all burnt, and there are burns on the face and neck. There is soot in the nose, and then if you take x-rays, there is patchy consolidations. All these point out to respiratory injuries, and in these patients, when you have these signs and the history, you have to electively intubate the patient. Don't wait for the signs to happen. So you secure the airway, give physiotherapy, nebulization, warm, humid oxygen, and again oxygen, especially if you're suspecting carbon monoxide poisoning. And then if required, you have to go for intermittent positive pressure ventilation. If there are any full thickness burns on chest, we have to do escharotomy. So the once airway is secured, and the next important step in management is we have to assess the percentage of burns and the depth of burns. So if it's a small burn, you can take the area of the fingers and from the whole hand area as 1% of the body surface area of that patient. So you can cut a paper of this size and see, put it on the wound and see how much percentage of uh, surface is involved. That gives a rough estimate. In small burns, you can use that. In larger burns, in hospital setup, you can use London Broader chart. So as you can see in the image, uh, for various ages, the area of head, thigh, and leg changes, and for other areas, for the torso, it almost torso and hands, irrespective of age, the area remains same. In children, the area of head is more than more. So when compared to the adults. So basing on that, you can draw the burns on the London Broader chart, and you can decide how much percentage of burns is there. Other simpler estimate is using rule of 9. So in rule of 9, uh, we take head and neck as 9% of burns, and then each arm has another 9%, each leg has 18%, and then torso, front 18%, back 18%. So all this total come into 19%, and then genitalia and perineum is 1%. So you can again draw the burn area on the image of the body, and then basing on the rule of 9, you can judge how much percentage of burn is involved. The next step in management is assessing the depth. The depth of or the extent of burn injury is both time and temperature dependent. At low temperatures, it will take a longer time for the burn injuries to happen. Say at 44 degrees centigrade, it will take at least 6 hours for the irreversible burn injury. At 70 degrees centigrade, it will just take 1 second for the epidermal destruction. say if water is at 65 degrees centigrade, in 15 seconds it can cause, in 7 seconds it can cause superficial partial thickness burns. In 15 seconds it can cause deep partial thickness burns. In 45 seconds it can cause full thickness burns. So knowing the history of the burns and immediate uh, first aid can can prevent the full thickness burns. So scald or the burns with the hot liquids is the most common type of burns we see. So normally they tend to be superficial burns with some deep dermal patches, especially if you immediately cool the wound. Uh, Scald wounds tend to be uh, deep full partial thickness wounds in young infants. Fats, that is hot oils, can cause a deep dermal injuries. Flames cause a deep dermal or full thickness injuries. Alkalis also cause deep dermal or full thickness injuries. Acids, if they are weak concentration, they cause superficial. If they are strong acids, they cause deep dermal injuries. Electrical burns at the site of contact will cause full thickness burn injuries. So, as we can see in the image, the superficial is the only the dermis is affected. In the superficial partial thickness, the papillary dermis is affected. In the deep partial thickness, the extent is up to the reticular dermis. Full thickness, the entire thickness of the skin is involved. So superficial thickness burns, as we have seen, they are extended till the papillary dermis. So there is either loss of epidermis or some blisters, loss of epidermis or blisters. The dermis looks pink, and when you press it, there is blanching and there is capillary return noted in the wound site. Normally, if you do a pinprick, there is sensation. Normally, these wounds will heal within 2 weeks without any surgical scarring. The management is non-surgical management. In deep partial thickness burns, entire epidermis is lost, and the burn depth is up to the level of reticular dermis. And the dermis doesn't look as moist as in case of superficial thickness burns. There is a fixed capillary staining, so there is no blanchability. And the patient will not be able to differentiate between the pinprick and blunt pressure. Without surgical treatment, it will take up to more than 3 weeks to heal, and it will heal with a hypertrophic scar. In full thickness burns, the burn skin is looks entirely different from the surrounding skin. It is a hard leathery feel, and there is no capillary return, and you can see the thrombosed vessels under the skin. You can stick the pin into the skin and patient will not have any pain. It's completely anesthetized. So that's all about the assessment of the depth of the burn injury. The remaining part of the management of burns we'll see in the part 2 video. Thank you.